been with Blue Shield since 2006, and prior to that, he served as the Senior Vice President of Health Plan Network Management, where he was accountable for unit cost results for all provider groups, hospital, ambulatory surgery, contracting for Blue Shield of California. And before he came to Blue Shield, he was with HealthNet of California. And Juan received an MBA from the University of California at Irvine, for which we hope to take some credit for his success. So,
Thank you very much. Is this on? We there? Yes. First of all, I'll say, Len, nice suit, buddy. Luckily, if this was the Oscars, I could easily see Ryan Seacrest saying, "Hey, who wore it better?" Luckily we're guys, so I think we can get beyond that. Secondly, I was like Dr. Feldstein said, I graduated from UCI in 1991, Graduate School of Management. It's great to be back. Actually, I took a walk on campus. I didn't recognize it. There's like 3 times more buildings than I recall. It's kind of embarrassing to be lost on a campus that you spent so many years at, but it happened. Okay, so I'm here to talk about a health plan perspective of our challenges in implementing the Accountable Care Act, and they are many, frankly. So let me read a couple of things. First, it was passed in March 2010. Yes, that was a good one, I thought, too. As has been said, so a couple of things here. Key objectives, aimed at holding insurance companies accountable, lowering healthcare costs, guaranteeing more choice, and enhancing quality of care for all Americans. Now, some of that may be true, but I will suggest to you that there's not a single thing, or perhaps almost not a single thing, that I have seen in the Accountable Care Act that will lower costs. From our end, as we've done the math hundreds of times, getting ready for going live, I'll go through in the next couple of pages the things that we see, and not a one of them actually makes costs come down. So I think that Marion was dead right. There is going to be sticker shock when folks see what's possible versus what was expected or desired. Secondly, bridge to 2014 when a new competitive insurance marketplace will be established. I guess the other thing is important to note, our company and I are very strong proponents of the Accountable Care Act. So please take my belly aching with a little grain of salt, right? The point here was to share our challenges, and again, there are many. The final goal, ensuring 30 to 70 million Americans who are currently uninsured. So here, I'm not sure if you can see this, but I'll read a couple of things here that really matter. First of all, in the 2010-2011 area, or time frame, grandfather status was critical, dependent coverage through age 26, having a college student, age 20 now myself, who I'm hoping when she gets done actually decides to leave the house and get a job. Although that's a coin toss at this point. I think it's a different era, right? Now it's like, Dad, I want the new car, not the just old car. I don't understand. But anyway, the emergency services, lifetime and annual limits that went away, OB-GYN referrals, no pre-existing conditions for exclusions for children, small business tax credit, et cetera. 2012, the Supreme Court upheld the Accountable Care Act. That was a huge event. And I think, as all of us know, it is the reason why it's now here to move forward. We've been working actually on getting our network ready for or actually for the fall, for October 1, 2013 launch in all 58 counties in California, all 19 regions. We essentially have been renegotiating contracts with 55,000 plus providers, doctors, hospitals, ambulatory surge, everybody who we have a contract with. And I'll touch on a little bit of the hard part there and what it means as we move forward. If you go to like the where we are here portion, individual mandate goes into effect very soon. Clearly what that means is folks, in fact, I'll go to that right now. Oops, not too far. Everybody has to buy, which is important. If you have guaranteed issue on the bottom of the page where everybody, as a health plan, we have to sell to whomever wants to buy. There are no conditions, historically, if someone didn't pass medical underwriting, they couldn't buy an individual policy. Clearly, that was a terrible approach or a terrible business scenario, because when all health plans had to do medical underwriting, if you didn't do medical underwriting and everybody else did, you essentially got all the folks that wouldn't pass medical underwriting elsewhere. So this is actually a very critical thing, and I support it strongly, guaranteed issue. The problem, though, the flip of it is, and the irony of all the fighting that ended up going to the Supreme Court, year one, if you choose not to buy, and it was said earlier, the policy for individual will be something like $7,000 per year. I think it'll be closer to $8,000, $8,500 per year. You can pay $95 as a penalty to not buy. So let's just assume you're, my 20-year-old, or let's say she's 26 or 27 at this point, and she gets the choice of paying $8,000 for a policy or $95. I think the worry here is an awful lot of folks, an awful lot of young folks, are going to choose not to buy. And that's a problem. And here's another reason why it's a problem. So community rating. We have to community rate everyone. So again, the cost of insurance must abide by adjusted community rating rules. And one of the critical items here is they cannot vary based on health factors. They can only vary, and this is critical, age by no more than a 3-to-1 ratio. Historically, at Blue Shield, we had like a 7-to-1 ratio. So that's huge, right? So here's what this really means. A 30-year-old is going to subsidize a 62-year-old, assuming that 30-year-old buys. And they get to pay $95 to not buy or $8,000 to buy, right? That's a challenge. That's a problem. Tobacco use, it's in the ACA, but technically not here in California, of a 1.5-to-1 ratio where you can price separately. Self-only or family enrollment. So the key on the bottom is also important. There are the 3 R's, right? Risk mitigation, risk adjustment, and reinsurance, which will help mitigate adverse cost and risk to health plans. So that's critical. The hard part is, quite honestly, we don't have the details of what exactly this means and how it will actually work. So the question is, will it really kind of smooth out the fact that there's a chance that younger folks won't buy? Bands are tighter. Let me come back here. There's a whole lot of other benefits. So I'll give you an example. As of year-end 2012, our company had 326,000 individual lives. Almost all of them in a PPO benefit plan, higher deductible. The PMPM revenue on that was about $200 PMPM, 200, 205. When you just bring it up to the Kaiser small group plan, just the change in benefits, plus the 3-to-1 ratio, plus the guaranteed issue, we've done calculations that without bringing in the risk profile of folks, that is a 15 to 20% increase just there. If you then bring in the risk of folks, i.e., you run a scenario where very few young people buy, a lot of older people buy, a lot of folks that clearly in the past couldn't qualify for medical underwriting, they clearly will buy, right? The potential increase in premiums run from 25 to 60%. And so my worry is that what we've got is something that is critical, it's important, it's necessary, it's the right thing to do, but no one might be able to afford it, or it will be highly potentially unaffordable. I think sticker shock is something that absolutely is possible, and we have to be careful of it. So, with all that good news, and, let me keep going. Essential benefits. That is another piece where, as you see here, the bottom line is what historically folks have purchased in individual marketplace in California. So we had 326,000 lives. Anthem Blue Cross has about 750,000. Similar profile in terms of PPO primarily rather than HMO. That bump in price is critical. What I want to do is actually, so kind of one thing that Governor Romney commented quite a lot in the fall, how his plan in Massachusetts had didn't compare almost at all with the Accountable Care Act. When you get down to it, if you look at it, it compared very well. And in fact, a lot of it was very similar. And so to me, what we've done is put a little time in studying, okay, what's happened in Massachusetts? Well, what happened in the first couple of years is the uptake of membership was enormous. The amount of uninsured was ended up being very small, so highly successful on that part. Problem was costs were just through the roof on the individual side. And the state had to do a couple of things, right? Because again, similarly to the Accountable Care Act, there's really no mechanism to bring costs down inside the law. What they did is create tiers on the hospital side. So folks that are members, or actually before that, first they pooled small group and individual in a pool. Small group essentially subsidizing individual, bringing the price down. Secondly, on the network side, they created tiers such that if folks go to a teaching facility, say like a UCI or a Stanford, there's a much higher copay out of pocket for the folks that go there. That's the highest. Then there's a middle tier and a lower tier. So what they've done is essentially brought folks to more community hospitals where the services are there. It is a way to actually kind of break up some of the provider monopolies that existed in Boston and other places in Massachusetts, like Harvard Pilgrim, for example, and force the providers to come to the table with rate concessions. Without it, I think we have a huge problem. So here in California, what is kind of that mechanism? So let me just explain a little bit, and I don't have it here, but for what we at Blue Shield, we've built a network that we literally just turned in, all 58 counties, 19 regions, based on the PPO panel, because essentially our historic membership is on a PPO panel. Couple things that are important there. Why the PPO panel and not HMO? Well, one of the things here that really matters is accumulators. On the HMO side, it's hard to do. There is no mechanism to do accumulators. We pay capitation to all the medical groups. That's not been resolved. So filing or going with the HMO network, not having that is a problem. Secondarily is risk adjusting, right? So the coding, just like in Medicare, coding is critical. In Medicare, though, if you code your HCC scores very well, what happens is the federal government gives you more top-line revenue. Everybody wins, right? The doctors that do the coding, everybody takes capitation, including ourselves, wins on the Medicare side because you pay on a percent of revenue basis. In this instance, what's going to happen is at year end, 6 months after year end, your coding is compared to the other health plans. And essentially, if your risk profile is higher, money comes from them to you. If it's lower, money goes from you to them. The problem is if you have encounter data that you're searching for diagnosis codes in, it's plain and simple not as good versus claims, right? So the hard part for us is we couldn't get our heads around going with the HMO platform when that was an inherent risk that at the end of the day, you could end up with a higher risk profile and give money to other health plans because it's a zero-sum game essentially. So that's another challenge, and for us, that's a real big reason why we went PPO. The last part is risk. I mean, the crazy part is it's not too long. I've been doing network contracting now since 1991, after actually barely getting out of class from Dr. Feldstein, because even though he's a nice guy, he's a tough grader, I'll tell you that. So the key here is the network itself, we had a whole bunch of medical groups that went under in the late 90s by taking too much risk. It's hard to know what kind of risk is going to come in. The Massachusetts example tells me it's going to be huge. Way worse potentially than we all assume. And the other part, I actually, now granted, this all sounds pessimistic. I'm an optimist. I think at the end of the day, it'll work out. I think year one's going to be terrible. I think year two will be better. And I think year three will start to get it right. But we're all in. We're going to go in 58 counties. We expect to get more than our fair share of folks. One thing that's critical that I think Len touched on, there's the cross where folks are, in Medi-Cal, lots of members go in and out of Medi-Cal a great deal. Something to the tune of 25 to 30% of those members go in and out. Essentially what that means is they're going to go from Medi-Cal to the exchange, from the exchange to Medi-Cal. It's critical for folks at the end of the day, like in Orange County, for example, that if we are the plan that has a good footprint and a good price, what we want to do is make sure that we connect directly with someone like CalOptima to try and make sure that the data goes with that member in both directions rather than it's just a name without any information. And what that means is there's a lot more connectivity that has to happen in every region between whoever is the number 1 or number 2 health plan in that region and the corresponding Medi-Cal entities. In some like 2-plan model counties, it'll be even harder, right, because there's 2 entities. But I think it's something that none of us have spoken about, but that type of connection and integration I think is critical to make this thing a success for those folks that need it the most. And lastly, I'll just touch on why, for us, so to kind of, why would providers, so we've been out asking providers for huge decreases actually, to be in our network for the exchange. We filed it, it's going to be a skinny network. It's by far skinnier than our broad PPO. It leans much more towards Santa Ana than Newport Beach, much more toward Fresno than San Jose or Palo Alto, much more to East LA versus Beverly Hills. Not shockingly, right? Because that is where the folks that are going to have a subsidy reside. And so for us, it's critical that we have a much broader footprint in that area because that population that has a full subsidy, we expect to be much closer to a normal distribution of membership versus folks that are just folks that couldn't historically pass medical underwriting. I'll give a couple of data points. Our spend on an annual basis for the 326,000 individual members we had last year was about $640 million to all the different providers in California that got those members. The key here is, and Anthem actually had 750,000, they're about 2.3 times, so I calculated their spend was like $1.4 billion. Put together, it's almost $2 billion in revenue providers in California got for individual membership. 1/1/14, or actually 10/1/13, all those folks are going to go through open enrollment. So when I've been talking to the leaders of provider organizations, it's like, look, you have X million dollars in revenue coming to you today. If you do nothing and you're not in, you can pretty much guarantee they will pick somebody else, including Kaiser, which is completely out of our system, right? We don't contract with them. So that is the kind of the why, and therein is the beauty of the Accountable Care Act. There's nothing in specific that made healthcare costs better. But the threat of $2 billion walking away from all these providers in California has brought people to the table to say, after the first few phone calls, mind you, it didn't take, didn't happen the first time out, that folks are willing to have a discussion about, okay, what's this mean? How do we do it? And I think that is the beauty of it, right? So I start with, there's nothing in there to help. At the end of the day, it's because it's going live that there is a chance that we all will have a much better network, albeit skinnier in terms of a price point that would help cover much, if not most, of the impact of all the extra benefits. 5 minutes, I will finish early. Thank you.